is. So our next session is from Ashlen Thomason, our speech-language pathologist and specialist from Arkansas Children's Hospital. She is also a member of our Medical and Scientific Advisory Board to give a presentation, Updated Speech, Language, and Feeding Findings from Children with SATB2-Associated Syndrome. So Ashlen, thank you.
Hi, everyone. It's really great to be here. Today is my grandmother's 100th birthday. Yes, thank you. So my maternal grandmother turned 100, and you won't be seeing me at the conference tomorrow because we are flying straight to Tulsa to go celebrate with her. Generally, when people hit this milestone in life, they might make the local news and they'll say, "What is your secret? How did you make it to 100?" And my grandmother's motto has always been to stay active and stay busy. Even though she was a homemaker and, was retired, she always kept after doing something. Well into her late 80s, she was caring for her great-grandchildren, my cousin's twins and their younger sibling. She would keep them all day because she could. She always had a garden, and I'm not talking about a little raised plot in the side yard, a garden. And she was gardening until she was 98 and taking care of animals. She usually had cattle, sheep, chickens, guineas. I hated those things. And so she was a busy, busy body. And at 98, she broke her hip and now ambulates with a walker, and she has slowed down quite a bit. And has had a pretty big decline in her health, but she's still with us, still hanging in there. And so I say all that to let you know that as the caregivers of people with special needs, I think you're all going to live to be well over 100. Yes, if the secret to life is staying active and staying busy. And I say that not because I encounter parents and caregivers of children with special needs in my job, but because I got a teaspoon, little dose of it as a nanny for a child with special needs when I was 20. So I spent that summer between college semesters caring for a 6-year-old girl, Olivia, and her younger brother, who was 4, and her older sister, who was 8. And I was tag teaming that crew with their mom, and dad was usually at work. And I was not a live-in nanny, but I was full-time, 40 hours a week. And I thought that this would just be a really sweet gig to get to spend my summer with Olivia. We knew of them, and I'd seen Olivia, and she was a cutie. Olivia has Down syndrome, but she is almost more affected by an anoxic brain injury at birth. And so I thought, Down syndrome, that's pretty easy. These kids are happy, and they want to have fun all day. I will be hanging out with this girl, playing high fives and tea parties, and it's just going to be so much fun. And I'm going to be making $2 more per hour than minimum wage, so this is a sweet deal. And what I was not prepared for in my summer with Olivia were a million appointments and elopements. And even though she was precious and we had the best time with her Lilo and Stitch soundtrack, dance parties, and playing with baby dolls, hitting, kicking, biting, scratching. And we had some hard days. One of our hardest days, we were headed to the pool. And in the parking lot, she grabbed a cigarette butt and put it in her mouth and wouldn't let it go. And so I fished that out of her mouth, and we had AFOs and getting her in and up the steps and got her into the pool. And Olivia wasn't yet potty trained. And so we're playing in the pool, and we're trying to stay safe and have a good time. And then there's screaming and a big commotion, and Olivia has gone number 2 in the pool, in the country club pool. And they have to shut it down. They have to clear it out. Olivia doesn't want to get out of the pool, and she is fighting me with all she's got. And it was just a really, really hard day. And the mom, Misty, those were her friends. Those are her peers at the country club. And so that's hard to get that stare down. And so there was the number 2 and the fight and the getting out and the embarrassment, and it was just a really hard day. And my now husband, but boyfriend at the time, drove across the state of Arkansas to come take me out on a date when I got off work. And so he shows up to surprise me. And I was like, I'm too tired to go on a date. I can't do it. And he was like, are those claw marks across you? And I was like, yes. And he was like, you've got to quit this job. And I was like, no, I love her so much. I love her. So Olivia was really easy to love, but difficult to care for. And what I did not have to deal with that Misty got so much more of that I did was her highly dysregulated sleep. Usually when I would come in to join the party, Olivia had been up all night long having a great time. And so I always got to go home and I was worn out. And that is busy, that is active. And so I don't always have great news to say when I am presenting on data about speech and language findings in individuals with SAS, but what I do have to tell you is just cheers to a long and happy life. All right. So I wanted to start off this morning by talking about our previous research. So we started seeing individuals in our SATB2-Associated syndrome clinic in 2017, and we started gathering data in our multidisciplinary clinics about the communication skills and the feeding abilities of individuals with SAS. And so back in the early days of our clinics, everyone got about 30 minutes. And we knew that this was a speech-heavy disorder. And so my colleague Beth Nutt and I set our timers on our cell phones to go off at 25 minutes so that we could cut it off. And so we, with that time allotment, did the best we could to gather the most data, to get the most information that we could about these domains in individuals with SAS. And so we gave some formal subtests for receptive language. We screened kids for apraxia, and the rest was a lot of parent report and observation. And so we had to analyze some samples and look at some rating scales and get lots of information from parents. And so with all of that taken together, we studied 61 individuals with SAS, and they were ages 26 months all the way through 29 years of age. So when I started looking at the old data set and our new data set in our longer visits, I got the data kind of muddled. I was trying to put the two together. So this is a slide of data from taken together all of our visits, our data from 2017 through our last clinic that just occurred on June 1st. So for many of the other domains, that data is separated. So what we know is that in our first look at the data in 2017 and 2018, we know that 72% of our patients were primarily nonverbal, meaning that they say less than 10 words over the course of a day. And now when we look at our old and new data, that number went up marginally to 75.6%. And the most common communication modality that individuals with SAS use is still gestures. And so once again, I got messy and combined these data from 2017 all the way up through 2022, both data sets, to look at the average age of reported first words, how old your child was when they uttered a first true word, and that was 28.8 months. So between 2 and 3 years of age. And that ranged from kids starting to talk at 8 months of age all the way through an individual, our oldest, to speak their first word being 66 months of age. All right. So this is kind of that old data, and then I'll talk to you more about our new data. So expressive language-wise, out of our children who do say words, their average spoken lexicon, the number of words that they use, is 28.6 words. That is amazing, and that's kind of inflated by some individuals who are so much more verbal than the rest of the pack. And so that's a range of 0 words to 500 words. And that included 3 individuals who said 200, 350, and 500 words. At the time, those were the individuals who said way more than what the other kids with SAS were saying. And so there's some data there about how if you can extrapolate that out by age and taking out those outliers, that those numbers of words are fell to less than 10. And 16% of those individuals that we studied back then had no words yet. no vocabulary words at all. Uh-oh. There we go. All right. So receptive vocabulary-wise, we used a formal test. The receptive vocabulary subtest of a formal test called the TACL 4. And so we look at most of our tests in terms of raw scores. How many individual items did they get right? Because ultimately with a standardized test, you take the individual number of items that an individual gets right, you compare that to normal, and the score is just going to be severe. It's going to be severe for everyone. But you can really measure true growth when you can see a raw score, see how many they get right, that they came back 2 years later and they got so many more right. And so raw scores give us more information. And so on this particular subtest, raw score below 15 is an age equivalent of a 3-year, 0-month-old child. And the scores range from 0 to 38, getting 38 individual items correct by pointing to that correct picture in an array of 3 when given a vocabulary word. And so 29% scored 0 by not correctly identifying any pictures. 76.8% had scores below the first percentile rank. But there was an overall trend of improvement in knowing more vocabulary words, pointing to more pictures correctly across time. Also in this old 2017-2018 data, we looked at MLU, mean length of utterance. When kids who are verbal are speaking, are they saying single words? Are they putting a couple words together? Are they putting together small sentences? So the MLU in that old data was 2.39 words. That's, of course, in our individuals who are verbal. We didn't just count in a bunch of 0, 0, 0, 0, zeros for our children who aren't speaking. And that ranged from most children who are verbal saying one word to a child who had a mean length of utterance of 6.75, so a child speaking in full sentences. When you take out that big time outlier patient, that drops to 1.67 words per utterance, so saying 1 to 2 words each time they speak. And then we use the communication function classification system. This is a scale that is more traditionally used in individuals who have cerebral palsy, but has been extended to be used in children with a variety of neurodevelopmental communication disorders. It's a simple scale that is levels 1, 2, 3, 4, and 5 that is just a quick rating system. It's very pared down when you're looking at communication. There's one for ambulation, there's one for fine motor skills, and for communication, it just looks at your ability to reliably send and receive communication across partners. So what we like about it is that it does include AAC, all right? So 73.3% exhibited problems with reliable communication with unfamiliar partners. That's just a problem. The most of the time, they can be a reliable sender and receiver of information with someone in their close circle, their therapist or their direct caregivers. And 16.6% were rated as a level 5, which is our lowest level. Seldom senders or receivers of communication, even with a familiar partner. And then we got data on apraxia of speech. We primarily gathered this data by taking speech samples. Though lots of our children came to us in clinic already with a diagnosis of childhood apraxia of speech from their local speech-language pathologist, we wanted to get these data for ourselves. And so we would transcribe utterances of the kids that we were seeing in clinic at the time. And so if a child said backpack, we would try to get them to say backpack a few more times. And we would look at what sounds and syllable patterns that they used and their inconsistencies and their vowel errors and how idiosyncratic those errors were to say yes or no, does this child have characteristics of childhood apraxia of speech? And they did. So of our verbal speakers in that first group of kids that we saw in those brief visits, all the kids who were verbal speakers for whom we could complete an analysis had characteristics of childhood apraxia of speech. Then we looked at resonance. That's the balance of how much of your speech vibrates through your nose versus your mouth. And so we want normal balance. You can be too blocked up, can be too nasal. And so with a history of cleft palate, children are at more risk for being hypernasal, having too much coming out of the nose. And so again, not many of our children are verbal enough to assess that, but in the children for whom we could make an assessment, 82.1% had normal resonance. There were some children who were too nasal, mildly hypernasal, and 7.1%, moderately hypernasal, and 10%. Then of the children who had hypernasal resonance, 60% had no history of cleft palate, which is interesting. And a history of cleft palate was noted in the other 36.1%. Drooling was another major finding in 63.3% of individuals with SAS. The average age of reported resolution, if it was going to resolve, was at 48 months, so around 4. The range of drooling cessation ranging from stopping at 2.5 years to 7 years of age. And among the 24 individuals, 40% with drooling, it persisted beyond 48 years of age. But a lot of parents told us it got a lot better when they were 4, but it is still present. It's still there. And so that was that other 41% who reported significant improvement over time. Feeding is a big issue. Overstuffing of the mouth during meals with the majority at 64.9%, difficulty chewing at 68%, history of pharyngeal dysphagia, so having a throat, face, swallowing problem, and that's where you get into safety issues with risk of aspiration in 60.8% of individuals with SAS, and there were 61.6% had no present signs or symptoms of aspiration. All right, then we were able to see 9 individuals across multiple visits in our clinic. And so they were seen a year apart. And so as far as receptive vocabulary, 77.8 pointed to more pictures on that tackle 4. They did better across the time. 44% made gains in reported expressive vocabulary, so reportedly saying more words, going up on their MLU. And then there were some kids who had no expressive vocabulary gains. And so kind of a little bit of a mixed bag, but mostly an upward progression. We also hypothesized that this would all come down to the type of mutation in the SATB2 gene, that we were going to see that those individuals who were talking had a specific type of mutation, the individuals who weren't might have another specific type of mutation. Overall, this is a wordy slide, but not so much. Really didn't confirm that hypothesis at all. And so, Beth Nutt and I, the speech pathologist on our SATB2-Associated syndrome team, were really relieved when we found out that we were going to change our clinic model to have a really nice, long, thorough visit with our patients. And so we meet with our patients for about an hour and a half to 2 hours to get much more thorough testing. And our goal in these visits is kind of multifaceted. So we want to get ongoing answers about how people with SATB2-associated syndrome communicate, how they're functioning. Do they plateau? Do they grow over time? Where do we kind of max out? What do those outliers look like? But we wanted to get a more thorough look at their abilities with and without their AAC. We wanted to look more at gestures. That's primarily how these patients are communicating, so we wanted to find something that measured gesture use. And then we also wanted our testing to serve the purpose, at least for third-party payers, to be their annual evaluation if they need that. So we're spending all this time testing them. We want this test to carry them through the next calendar year, or in some school districts, 3 calendar years, so that if you're billing speech assessment time, that test can be used by your local speech language pathologist to plan your goals and show your qualification for speech therapy services. So we gave direct standardized tests. That includes a full language test called the TELD-3. All of the tests that are bolded are tests that we gave before. So that tackle 4 vocabulary, we gave again the receptive and expressive one-word picture vocabulary test, and the MacArthur-Bates communication inventories to look at gestures. As far as AAC use, we're still using that big scale of 1 to 5, but we also used an instrument called the communication matrix. For speech intelligibility, namely apraxia, we were using the Kaufman Part 2 of the KSPT. We were still doing an Apraxia screening and informal clinical analysis of a sample. And then we kind of looked at these other domains through parent report. And so our new cohort included 25 individuals with SAS, but they were seen across 30 visits. So five patients were assessed again. They ranged in age from a child who was just under 3 to a young adult who was 20 years of age, 68% males, 32% females, and these visits were from 2020 through 2022. All right, so for all of my graphs, the x-axis, the bottom, is age in months, okay? And so you're looking at birth at 0 all the way through, and the individual who's 20 was like 248 months of age. So for all of these graphics, that is age. And on your y-axis going up, those are all raw scores. And so we want to know, when we're answering all these questions, do their scores go up with age? How does that look across the lifespan? And so you would think for all of these that are in, our number included would be 30. But then, being caregivers, you would know that it's not that way, because sometimes you're going to be shocked. Your kids don't participate. Yeah. And so you'll see some N of 20, N of 23. We just couldn't get the test sometimes. And so you'll see some variability there. And so estimated spoken vocabulary came directly from caregivers. Most of our caregivers can tell us down to the number exactly how many words they had. Sometimes that's complicated. They're like, okay, well, it's 7. But we really haven't heard him say the dog's name in like 2 months, but he is sometimes saying pizza. So like that's kind of 8, but we might throw out that 7th word and include this new word. So for those, when they give us a range and they say it's 10 to 11 words, it's 10.5. So that's where our data looks a little bit messy. You know, kids have an average of this many words. So when we look at these individuals in this new cohort and we look at their number of spoken words across their lifespan, you can see that there's still a lot of kids at 0 and less than 5 words, kids who just aren't using any words. But you can see that, yes, kind of, with age, there are some kids who have some more spoken vocabulary words over time. And so 11 out of 25 of the kids that we tested have never said a first word. And then that does, if we include one child who was seen in this clinic who is extremely verbal, I'm talking has straight up normal communication skills relative to their age, that is an average of 49.1 spoken words. But if we exclude that child, the average out of our verbal communicators is 16.3 spoken words. And then to put that in perspective of neurotypical language development, a child should have at least 1 word by 12 months of age, and the average number of words of a child hitting 24 months, 2 years of age, is 200. So, you know, with most of our kids having less than 100, they're kind of at that 18 months range. All right, mean length of utterance, that MLU, that comes from observation and caregiver report. 17 kids with verbal ability included in this group. If we include our outlier, our highly verbal child, the mean length of utterance is 7 at almost 6 years of age. And that would mean an MLU of 1.5. If we take that child out, that MLU is 1.1. So the majority of their utterances are 1 word. Occasionally there's a 2nd word in there. And that's the age equivalent of a child less than 18 months of age. All right, then we gave the tackle again. So the tackle for vocabulary subtest, this is where you give a child an array of 3 pictures. You say a vocabulary word, and they point to the picture that corresponds to that word. And so this test is standardized on children ages 3 through 11, and we presented the photos. I can't break copyright laws, but I can tell you what some of those early words are. So we start with home, box, girl, drink, cutting, yellow, father, jumping, and so forth. And so the words get a little more advanced as you go. And so basically we see an overall trend, and we gave all individuals, and we count those kids with double visits as different individuals at different points in time for their age. It does go up. It goes up with age. Our kids are understanding more, showing understanding of more vocabulary words as they age. There are still some kids who can't point to any. And that is why we use other tests. I can't tell you how many times I get to the word jumping and your children hop across the room, okay? And so it's like, yes, Betty, I know that you know what jumping means. Can you come over here and point to the picture? No. And so sometimes I get out those pictures. We have a few colors on there, and one of the prompts is for yellow, and there is a blue option, and your children like blue more, and they will shake their head no and point to blue. I'm like, I know you like blue. I know. And you just can't capture that. And you also can't capture some really marked progress in joint attention and the ability to know what that pointing kind of task is over time. So we'll see an individual at a visit, and they can't hang with you to look at what you're looking at to point to anything. They just can't participate. And at the next visit, they get it. And they might look at me and look at back and forth in the book and smile, and they might just point to their favorite one, or they might point to all three. But now they've got it. Okay, I'm pointing. They don't progress in their score. That's still a score of 0. Okay, and that's what these data don't show, and that's why we use some other tests to get at what we're looking at. And so to put these in perspective, a raw score of less than 15, it is an age equivalent of less than 3 years of age. So most of our children are functioning at less than that 3-year level. All right, then we used the TELD, the Test of Early Language Development. It's for kiddos 2 through 7-11. It looks at receptive and expressive language. It's got some toys and some parent report items. It's not standardized for use of AAC, but there's some AAC gesture things included in what they're testing. And so for some of those early receptive items, we look at them stopping in response to an adult voice, looking up when their name is called, responding to a command such as come here, identifying 2 toys out of an array, pointing to their mouth, nose, and eyes, pointing to 3 out of 5 basic objects from an array of pictures. And then expressively, some of those early items include stopping babbling when aware that others are speaking. A lot of these children don't babble. Initiating, vocalizing, and babbling appropriately, responding to hi and bye, using exclamations like uh-oh, using 2 or more action words, saying 10 or more real words appropriately. That's kind of where most of our kids top out. So 24 kids were able to participate in the administration of the TELD. Their average raw score for their receptive side, for what they're understanding, was a 7.3. And so if you score less than 5, that's an age equivalent of less than 18 months, and a raw score of 8 is at 2 years, 1 month, and raw score of 14 is at 3 years, 1 month. And so it also appears to somewhat trend up with age, which is good. All right, then we administered the expressive side of the TELD, and we scored that without formal AAC, just straight up as the scoring administration allows, mostly for spoken language, very few gestures. But then we scored that with a child using some high-tech AAC. And by that, we don't just mean talkers. We mean children using formal signs, writing out their responses, any kind of formal, reliable AAC, not something that a caregiver would only understand. And so with that, the average spoken only score was 6.72. The average spoken with their AAC was 7.12. So you see a little jump when you allow for that AAC. And again, most of these children functioning below a 3-year level. Then we use the receptive and expressive one-word picture vocabulary test. And so with the receptive one-word picture vocabulary test, you have to pick out your picture from an array of 4. We had 26 individuals who could participate. The average number of words selected was 20.6 words correctly identified. And again, that score of 20 is about a 2-year-old level. And so you do see that receptive vocabulary going up with age. We did the same thing on the expressive one-word picture vocabulary test. This is where we just have confrontational naming task, show a child a picture and say, what is this? When we allow for spoken only, you see those pictures to the left. And then when we allow for spoken words plus any formal AAC, you see that score on the right. And that's where we see a big jump with that average score with just spoken language only being 3.3 items, but that average with formal AAC going up to 9.14. So AAC is where it's at for facilitating better expression. All right, then we once again administered that communication function classification system. Well, really, we didn't administer it. We ranked children for where they are. Level 1 is normal. You can effectively send and receive messages. Level 5 is seldom, even with a familiar communication partner. And so looking at this across time, whereas we want our trend line to be up across age, kids getting better with age. For this one, since a score of 5 is bad and a score of 1 is better, we would love to see a beautiful trend line across age going down. Didn't necessarily see that. Lots of kids are kind of at a 3, where they can effectively send and receive messages with a familiar partner. All right, then we wanted to look at gestures. Your kids love to gesture. That's their primary modality. And so we use the MacArthur-Bakes Communication Developmental Inventories, words and gestures. There are several different inventories that are used, but we selected this one just to be for this population. And so it's designed to track development of gestures with age. It is all caregiver report, and so if you've been to this clinic, this is when Beth or I handed you that clipboard and you were filling out phrases that your child understands, gestures that they use, play activities that they participate in. And so it has some normative data to track development, but it's not valid for our population because it is normed on children under 18 months of age. Many items are not age appropriate, and so it's not that your child couldn't do it, it's just that you haven't worked on that. You're not playing peekaboo with your 12-year-old. And so there's some of that in there. So there's not really a perfect test to pick out for gestures for our older individuals. And there are cultural and regional differences in play. And so many parents, especially from other countries, will say, what is this game? What is that? I'll even say one of the items on there is playing So Big. I'm from Arkansas, born and raised. I have no idea what the game So Big is. Maybe you guys know, but I don't know what that is. But this little piggy isn't universal. And then autism differences. Many individuals with SAS have autism. Children with autism play differently. That's not big news. So this inventory has many different subsections. And so the first one is understanding of gestures, understanding things like come here, give me a kiss, don't do that, sit down, let's go bye-bye. Okay, and so there were 21 individuals who filled this out. The average number of phrases understood out of 28 was 19.5. Kind of see this go down with age, which is really interesting. All right, then use of first gestures, use of things like extending your arms to show something, waving bye-bye, shaking your head no, extending your arms to request to be picked up. There were 12 of those items, and the average was 9.17 of those gestures used. Uh-oh, I think I just hit somebody with a laser. I'm sorry about that. Wrong button. All right, games and routines. There are 6 of those. The average that we got was 3.3 of those games. Those games were peekaboo, patty cake, So Big, chasing games, singing, and dancing. Again, you see some of our mid-range kids have a little bit of growth, but not much on our older kids, and I think that that's just because we don't do those anymore. Then actions with objects, things like brushing your teeth or pretending to brush your teeth, putting on a hat, flying a toy plane, pushing a toy car, throwing a ball, pretending to pour. Out of 17 different actions, the average was 9.9. And again, a little bit of growth with our middle of the group and not much with our older kids. Pretending to be a parent, again, our teenagers and young adults probably aren't going to be playing with baby dolls as much as our little kids. There are 13 items for this, and the average was 7.3 out of 13. Things like pretending to put a baby to bed, feed it a bottle, rock it, and so forth. And then imitating adults, actions like sweeping, putting a key in the door, hammering, vacuuming, watering plants, etc. There are 15 of those. Individuals with SAS having an average of 9.3 items that they can participate in and do. And then the main test that we give and rely on that we feel like is informing your local speech-language pathologist the most is the communication matrix. So the communication matrix is a beast to give and write up, but it writes up all the nitty-gritty details in a very stepwise way of what your children do to communicate. They hopped across the floor when you said jumping, and that counts, and we have it all levelized. And so we have these 7 different levels of communication. All right, and it starts with levels 1 and 2, and those are caregiver dependent. So those are actions that a caregiver has to be able to tell what that child is meaning in that communication. And that starts with pre-intentional and intentional. So intentional behaviors aren't necessarily intentionally communicative, but they did something on purpose. Then you have your things that are intentionally communicative at levels 3, 4, and 5. And then levels 6 and 7 are your language. And so you are using a formal AAC device, you're using a sign, you're writing a word, and then language is combining 2 of those. So no versus no broccoli. All right, and lots of cool things in between for each. So these data are a little too messy to report. All right, so we have kids who in one domain are at a 2, but then they will get out their talker to request and they make a sentence, but for the most part they're using these informal gestures that really rely on the caregiver to interpret, and I need a statistician to help me report these accurately and what they look like over time. But I'm sure you're not surprised that your children are all over the map with this and communicating at different levels of competency for all kinds of functions. And we look at their communication for refusing, for obtaining something, for their social interactions, and for their ability to give and receive information. And most attain at least to level 3, but that's again tough to filter out. All right, we continue to try to give an Apraxia screening from the Linguist Systems Articulation Test Apraxia Screening, and we tried to give the Kaufman Part 2, and these were for our verbal individuals who could participate. The LAT Apraxia Screening, you can see those cute pictures down there. They have multisyllabic words, and you have the child say it 3 times. Eyelashes, 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 dinosaur, 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 computer, 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 and so forth. And you transcribe each one, and you look at their consistency. So even if computer was poo-ah, 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 that's consistent, okay? And so doesn't necessarily point to apraxia. And so then the Kaufman is the test that most of your speech-language pathologists use to diagnose childhood apraxia of speech, and Part 2 is where a lot of individuals with childhood apraxia of speech break down as far as their ability to make a motor plan beyond those low-level syllables. And so we thought that would help with therapy planning as well. The problem was getting our kids to participate reliably. So we, again, had an outlier patient with completely normal communication skills, and their only sign of childhood apraxia of speech was inconsistency across trials in 8 out of 12 items, but this child's speech was completely intelligible. No regular errors, but when you have that child say dinosaur, 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 they get a little tripped up, which is really interesting. For our other 3 patients who were able to participate, they got scores of 7 out of 12, 1 out of 12, and 1 out of 12, and all had diagnoses of childhood apraxia of speech coming into their test with us. And then we tried to give the Kaufman Part 2. In that outlier patient, they scored a 61. They were perfectly fine. We completed that with another verbal patient, and they got a score of 16, very, very apraxic. We attempted the Kaufman Part 2 with 3 patients with raw scores of 6, 0, and 0, and they all their testing was discontinued due to perseveration. And so their motor plan was reduced to just something like an So, okay, say 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 and so when you get kind of 6 uhs in a row, you're not really getting anything else, and it's just kind of moot to continue. All right, so then we looked at, in those 5 individuals who came to our longer clinic more than once, their data across time. And so the 2 lines in those colored bands represent those individuals in their 2 visits. So the same child is yellow. Their second visit is always the one on top. So let's kind of look through this mess. For one individual, their number of spoken words went from 1.5 to 0. For the next individual, stayed at 20. For the next one, went from 75 to 100 words. The next individual stayed at 0, and the next individual stayed at 3. For mean length of utterance, the child who was saying 1.5 words had an ML, in yellow, had an MLU of 1, and that dropped to 0. Child in blue stayed at 1. The next child went from 1 to 1.5. She had a big growth in her use of 2-word utterances at her next visit. Primarily nonverbal child in green stayed 0, and our last individual, even though they're using 3 words, they use 1 word at a time. For our TELD, you can look at those data for their children for their TELD receptive and expressive raw. For that first child, they went down. For the second child, marginal growth in receptive. For the third child, a drop in their receptive score, but growth in their expressive. Marginal drop in the child in green, and then could not give that test on the second visit to the child who scored 14 and 11. And then we look at their receptive and expressive 1-word picture vocabulary test. That second individual had a lot of growth on their expressive vocabulary with their AAC from years 1 to 2. The same thing happened with the girl in pink. And then on that second visit in the child in orange, they went from having 0 to 23, which is huge. CFCS level didn't really change much at all. When we look at their ability to participate in the Kaufman, can't really, and the linguist system articulation test screener, can't really get much data over time with these kids, not a lot of change. And then when we look at their ability to use gestures and play, most of the time there was a trend up, sometimes not, sometimes a little bit of a trend down in their ability to understand phrases, use first gestures, games and routines, and so forth. All right, when it comes to our findings with feeding, drooling, and resonance, we didn't really see a big change in our longer visits. We weren't formally testing those things. We were just noting them clinically. No big change. But what I will say is that parents always ask us, what's missing from our child's plan? What could we be doing better? And it's feeding therapy. I'm surprised at the number of your kids who are not getting feeding therapy, even though you're telling me that your children are choking throughout their meal times. They are on special modified diets because they can't chew age-appropriate foods when they are chewing. And I see this in my room. It's just coming out of their mouths. And that's not fun at Thanksgiving. That's not fun at a birthday party. And so if your child's chewing is not age-appropriate and not at a level of social acceptability that you want, your child probably needs feeding therapy. All right, so overall, this new cohort of kids in these longer visits didn't change much about what we recommend. To hit all the domains that your kids need in their therapy, they need 90 to 120 minutes to get to the receptive, expressive language, whether you're going the formal AAC route, the spoken language route, where you're by and large going to have to treat their childhood apraxia of speech or both, and to get their feeding. And so more in-depth data, but not a lot of change to our recommendations. What questions do you guys have? Cassandra, are we doing the microphone bit? Cassandra's been my table buddy. I don't know all of your names, so I'm sorry if I don't remember you.
I have 2 questions. Is that
Yeah.
okay? All right. It's rather quick. So our son stuffs his mouth, and what they're doing is encouraging him to take one bite, put the fork down, take a drink. It's not really working. So my question would be, do you have another idea? And then the other question is, when he was going through the speech evaluations when he was younger, he would, and I bet your kids do this too, is they would ask him, show me the cat, and he would look right at the cat, but they couldn't score it.
I know.
So, and I know, like, there's technology with eye gaze now,
Yes.
AAC. So what is the progress in SLPs using eye gaze when they're assessing?
So we generally, unless the child has adaptive equipment to use eye gaze for pointing, we don't get that data. But when we use something like the communication matrix, we can know, oh my gosh, they use this level 3 behavior of looking back and forth between their choice and the person. And so that's included in a scale where we're looking at all these different types of communication modalities, whereas a normal standardized test comparing a child to the general population absolutely expects the child to point. And
Sometimes the evaluation comes before the AAC.
Yes.
So at some point you gotta-
Yes, they do. And so, and we love to assess kids with their AAC, of course. And we always want you to bring that with you to our clinic, and your speech pathologist wants you to bring it with you to your evaluation as well. As far as the oral hyposensitivity that comes along with overstuffing the mouth, there are, and I'm not a feeding specialist, but there are a different range of techniques, and one of those is sometimes some sensory priming or modification of what's happening with the bolus. So using a super spicy, sour, high sensory input bolus can sometimes meet a child's sensory need so that they don't feel the need to overstuff to get that sensation. Sometimes there's some priming with lemon swabs, different things like that. And so again, I would talk more to a feeding specialist, but it does need to be addressed. Yes.
So my question is about regression and plateauing, specifically with speech. I picked up on, especially in those last few charts, in kind of just your body language and discussing some of the negative changes. Our daughter will be 13 next month, and 2 years ago, I would have said she was in that 250 to 300 word vocalization, verbal language, very clear, spoken. And in the last 6 months, we've seen huge regression with no understanding of where that regression is coming from. No major changes in EEGs, no major changes in speech. She gets 4 30-minute sessions a week, which has been consistent in all of her school years. And so challenging to wrap our head around where is that coming from. And our neurologist has encouraged me to ask at this conference, what is known in this syndrome? Because it might not be anything we're doing, but just part of this syndrome.
So my typical answer is to look into a child's history of autism and seizures, because those are the two main subsets of kids that we see who have regression over time. The little girl in pink, not going to say her name, who had some regression, she just wasn't participating the second day, and that's not what you're looking at all. But sometimes that messes with our data. You know, she was having a good day and totally with me and attentive and got great sleep and did a great job her first visit, and then you see her for a second visit and she was just telling me on her talker, no. And so with the normal EEGs and no autism diagnosis, I don't know what that would be. I don't know what that is yet, but we're looking, but I just don't know. But it's sad, and we hear it a lot, and I don't know if there's something with some kids in their development of words. The parents will say, they have 10 words. They've always had 10. Now those 10 words have changed, but we get 1 and we drop 2, when we get 3 and we drop 2, and so there's kind of always 10 on deck, and I don't know what that is. But again, we see it in more kids with autism and seizures, but I don't know, and I'm sorry.
No, that's a great
hard,
answer.
So hard.
Okay, thank you.
Hi, I've got the virtual questions here. So I'm going to start with the first one from Katie. My 8-year-old SAS son is verbal, but the clarity of his speech is difficult to understand. It sounds like lazy speech, not fully pronouncing his words. I would say he sounds mildly hypernasal too. What kind of speech therapy is recommended for that? He has language, but how do we help him so that he can better communicate with unfamiliar partners?
Aside from one individual that I've met and one individual that I've read about in a paper, children who have verbal ability, who have SAS, have childhood apraxia of speech. With the lack of clarity, childhood apraxia of speech needs to be ruled out, and that's a specific type of speech therapy that addresses motor planning. Traditional speech sound pronunciation approaches do not work with childhood apraxia of speech. Motor planning therapy.
Great. My next one is from Chelsea. So for those of us with nonverbal kiddos who utilize an AAC device, would you recommend the speech therapy be more focused on prompt-driven therapy, aiming towards verbal speech, or focusing the speech therapy to be more AAC-driven, aiming towards the alternate communication?
I would aim towards alternate communication. And I know that's not fun to hear. We want our children to talk, but I would aim towards alternative.
Great.
It's where I see kids maximize their abilities.
Hi. You saw my son last October, and I just have to say it was probably the most thorough and engaging therapy session he has ever had, honestly.
Thank you.
But also in the last, so he's almost 4, and in that time we've introduced a autism diagnosis.
Yes.
So over the last 2 months, he's done a lot of like tapping, which I think is his stim. It's on tables, it's when he's super excited, and his speech therapist is having a very hard time with it, and she calls it raking and is saying that it's behavioral and it's distracting, but no other therapist has ever mentioned that it's a distraction. So my question is, I guess, in terms of speech therapy, how much of it is a behavioral curb versus, I guess, before you can actually get to a lesson, if that makes sense?
With your individual child on what you're reporting, to be brief, I would say it might be meeting a sensory need.
Yeah.
And so work with OT, and if it's not an obstacle, and it's meeting a sensory need, it may be getting your child where they need to go.
Yeah.
But therapy dosage is extremely complicated. It's like, how much does my child need across how many sessions? Therapy dosage is all about maximizing number of responses in a short or long period of time. And children with SAS behaviorally have trouble with that. And so ideally for good apraxia therapy, you're getting all of these responses in a really short time period, and they've got great attention, and we don't have that. And so behavioral wise, getting the right dosage of therapy within your session, maximizing those responses with their attention, behavior is an obstacle. And so those are 2 big picture answers to your question.
Cool, but I
Sorry.
appreciate it. Thank
Yes.
you.
And I know that I'm over time. Do I need to?
We got a couple more minutes.
Okay.
All right, so I have another virtual, and Chelsea, I'm happy to lug my computer up here for you. So have we seen any success with SAS kiddos with a saliva remediation therapy? My daughter's SLP has recently tried to focus more on saliva remediation therapy to help with drooling and motor planning. I'd love to have your insight on that.
So we recommend that type of therapy, but in our individual clinic, if that has maxed out and your child just hasn't made progress with lip competence and the ability to keep the mouth closed, we do send our kids to ENT. Dr. Zarate, what kind of shots are those? They're Botox for the sali area? Yes. So we, there's only so far that speech therapy can take you with drooling cessation. So lip competence, yes, absolutely, sometimes, yes. And so, anatomical challenges as well.
So I had a question regarding the AAC in
Yes.
particular, and there are so many different softwares and programs. What have you seen as part of the study has been the most successful, this thing? Because I've had trouble with conflicting ideas from the school and my, private speech therapist, wherein they kind of talk about the grid area and how they can navigate, just because Sanjana has some motor planning issues as well. So by the time we can even get through a lesson, right, we're trying to figure out whether this is right and whether it can sustain throughout, because that could be her primary communication device.
Yes. What I see by and large is kids who were given a device that is too advanced for them to navigate. Way too many icons and navigation that is way too difficult for what they have the capacity to do. And so they were given this device and they say they just don't use it, they don't know how to use it, they never open it. And it's just because the child has too many choices and they don't understand those words, they don't understand how to get from one page to the next. And so I'm a big advocate for PECs and switches, starting with lower level AAC that your child can use reliably and functionally, then move on to your high-tech talker.
But for PECs, I think you need to have good motor planning to be able to kind of carry that and navigate it.
Yes,
So,
but not so much with switches. And so I love to send kids to a good AAC specialist, and you've got a couple coming tomorrow because kids have complex bodies. And so we have things like eye gaze and switches and things that kids can use who have challenges with even with being able to navigate, like a child who had normal motor planning and abilities would be able to. And so a good thorough AAC evaluation with a specialist who's used to just the kinds of kids that need AAC and their complex bodies across sessions is usually best.
And they would probably have some more recommendations on some techniques that we could kind of take and
Yes.
socialize.
Yes.
Hi, you actually saw our Joe in June, so it was like 2 months ago.
Yes.
But again, it was also a very thorough evaluation.
Thank you.
But our Joe is almost 8, and we're just now getting to the AAC, on the AAC train. You know, he's been kind of left
You
behind.
guys had your eval, right? You
We've
had
had
your
the eval, and it's on the way,
Okay,
but
okay.
we're so far behind the curve. I'm seeing all these kids so much younger than he is. Typically, what kind of hurdles would we have to overcome? Because his communication is already habitual and ingrained at almost 8. So I feel like after watching all these other children being so successful, we're going to have a harder time. So what should we be focusing on now, and what kind of hurdles would we be looking at in the future?
I don't think I have an evidence base to pull from. You know, like we don't have great studies of kids who have had later introduction of their formal AAC. But I imagine it's going to be just a big lifestyle change and a big switch from using more gestures, facial expressions to using this other modality. And so I think like immersion, you know, using it at home and responding to it all the time is really going to be your best way to get him to use it the most. You know, Allison mentioned always carrying around the Rice Krispie treats, because if your child is hitting the Rice Krispie treat button and you don't give it to him, it loses its meaning. My husband got annoyed with me because my daughter would sign all done. She had feeding issues, and I would get her right out of the high chair, and I was like, she's going to stop signing if it stops meaning anything. And so sometimes granting requests and responding to their messages no matter what is what you need, even though behaviorally it's not fun. But full on immersion, using it all the time and responding to those messages is key. I think that may be all of our time. Thank you so much.
That was a lot of information, so I hope that you guys all gained some extra knowledge to equip yourselves with. Ashlen, thank you so much for being here with us. I want to let you guys know that we have a 15-minute break. We have coffee and some juice outside in the hallway, so get up, stretch your legs, step outside. I hear everybody saying they're cold, so warm up, and we'll see you back at 3:15.